So without taking much of your time, I'm having our first presenter who will be presenting in physiotherapy obstetric care, advancing maternal function and fetal mental well-being through evidence-based interventions. She's a physiotherapist, a global health scholar, a practitioner, a health professional, educator working at the University of Zimbabwe. She's passionate about advancing equal opportunities and access to health and education. Her work focuses on strengthening faculty development, focusing collaboration and reciprocal partnership. She's particularly interested in global health education, cardiac rehabilitation, women's health, including pelvic rehabilitation. So may you please help me to welcome to the podium Miss Regina CHIGWEREMBA.
Let's say I'm going to such a good way to look myself. I hope I live up to what has been said about me. My name is Regina CHIGWEREMBA. I'm a physiotherapist. I've been practicing for over 12 years around the country and a little bit outside as well. And currently I am lecturing at the University of Zimbabwe. And part of what I lecture is on the role of physiotherapy in obstetrics and gynecology, hence my presentation. So most people, when we talk about physiotherapy, I will have to admit that it's usually to do with the physiotherapy to get a sputum sample or to clear the chest, and that's the extent of it. But our role does extend beyond that to look at functional independence and improved outcomes in maternal patients as well. So the goal of this talk is to explore how physiotherapy improves outcomes for obstetric patients through targeted pain management, mobility enhancement, and comprehensive well-being promotion. So we do address various challenges, which include antepartum challenges like back pain, pelvic girdle pain, fatigue, mobility limitations, risk of gestational diabetes and preeclampsia, anxiety, fear of delivery, reduced quality of life. We also look at postpartum challenges like urinary incontinence, pelvic organ prolapse, persistent musculoskeletal pain, postpartum depression, as well as functional limitation. And we also focus on return to physical activity and occupational health. Yeah. Critical fetal risk that we will address or have that role in addressing include pneumonia, low birth weight, and NICU admission, which are directly linked to maternal inactivity and pregnancy complications. So we're going to take a look at prevalence of pregnancy-related challenges. Pelvic girdle pain, low back pain, and pelvic floor dysfunction are among the highest challenges, prevalences of challenges that physiotherapists will address. And these conditions impact maternal and fetal unit through reduced uteroplacental perfusion and altered growth trajectories. Pelvic girdle pain has a prevalence of 25 to 45% in African cohorts. This was from a study in Malawi. And low back pain up to 62%. This is also echoed in Zimbabwean cohorts. And pelvic floor dysfunction, 12 to 35%, although I do have an inclination that this is due to underreporting, so this might be lower than what it actually is in practice. So here on this table, we're just looking at the prevalence rates again. You'll find that for all these issues, we've got higher prevalence rates in Africa compared to first world countries. And pelvic girdle pain and low back pain being the highest. Then we also have mental health issues coming in with prevalence rates that are almost close to 30%. So for physiotherapy to be effective, the assessment has to be comprehensive, and evaluation forms the foundation of effective maternal care. So we'll look at what's the evidence base. Where is this coming from? It's not random. There have been several randomized control trials, meta-analysis, and Cochrane reviews that back the use of physiotherapy in managing pain, mobility, and mental well-being in maternal patients. On pain management, we use targeted interventions to reduce musculoskeletal discomfort, to improve functional capacity. And this is the overarching goal of physiotherapy. In enhancement mobility, we try to support daily function and promote safe physical activity throughout pregnancy. Mental well-being, exercise and relaxation techniques, which students are trained from their first year, help to reduce anxiety, lower depression risk, and improve coping mechanisms. So there are a lot of international endorsements that promote that actually acknowledge the use of physiotherapy and exercise therapies during pregnancy, such as from the World Health Organization, the American the Royal College of Obstetrics and Gynecologists, and American College of Obstetrics and Gynecologists. So our core interventions include education and body awareness training, tailored exercise prescription, which I will highlight. There's manual therapy, massage, mobilization, which can be soft tissue mobilization or joint stabilization, pelvic floor rehabilitation, and breathing relaxation techniques. So supervised exercise programs significantly reduce the pregnancy-related low back pain, and also they reduce the significance of the prevalence of pelvic ghetto pain. It's been shown that women who are left with unaddressed problems during pregnancy can have up to a 12-year recurrence of low back pain, disability, and difficulties in return to work, which is why it's important to have this addressed early. And then manual therapy benefits are demonstrated to decrease pain intensity and improve quality of life. And this also includes use of electrotherapy, such as TIN. These interventions reduce reliance on pharmacological pain management, aligning with maternal safety priorities outlined in current obstetric guidelines. So we'll talk about maternal wellness and metabolic benefits. Closer to me here is an infographic from the Royal College of Obstetrics and Gynecologists, from studies that show that 150 minutes of moderate exercise per week in pregnant women with uncomplicated pregnancies helps to reduce the risk of preeclampsia, increase activity, and this is shown to also reduce the risk of developing gestational diabetes and macrosomia. So RCTs demonstrate that prenatal exercise improves mobility and reduces gestational diabetes risk. Structured activity programs tailored by the physiotherapist can decrease work disability due to back pain, like I highlighted earlier. And metabolic benefits. Exercise improves maternal glucose metabolism, lowering fetal macrosomia risk. So exercise, of course, is tailored to each patient, depending on their individual needs. If they were not very active, they can start with home exercises, monitored, and then gradually increase to aerobic exercises and strengthening exercises as well. Okay, and then on pelvic floor health, looking at the long-term impact, meta-analysis with randomized control trials of about 1,300 patients show that pelvic floor training reduces urinary incontinence in late pregnancy, and that there's a continued reduction in incontinence rates, which extends beyond the postpartum period. In terms of long-term prevention, these interventions lower long-term risk of pelvic floor dysfunction. Pelvic floor dysfunction is among one of the reasons why there is maternal stress, and helping address this will reduce maternal stress and also improve maternal outcomes. And also looking at systemic benefits, long-term maternal health gains reduce surgical and rehabilitative care costs. Right. So in conclusion, there are immediate benefits, long-term benefits, and fetal benefits as well. And these include reduced labor complications. RCTs with patients of about 2,000 to 5,000 patients showed that patients who were actively exercising during their pregnancies for up to 6 hours a week had a lower rate of episiotomy, cesarean section as well, and faster postpartum recovery in the first year. And we also have enhanced maternal confidence and coping. And then in terms of long-term outcomes, we've got reduced risk of pelvic floor disorders, healthier birth weight distribution, and reduced NICU admissions. In terms of fetal benefits, mothers who were exercising during their pregnancies, their babies had improved APGAR scores, particularly in first minute and at 5 minutes compared to non-exercising nulliparous women. And then we also had optimal growth trajectories and better neonatal outcomes. I would like to note that in some texts, it is said that women who exercised more during their last trimester of pregnancy, particularly from 36 to 40 weeks, generally had babies that were lower in weight by maybe 400 to 600 grams, but this was not indicative of fetal restriction. So these are some of my references. Thank you.